Cardiology for accepting our invitation to participate in this webinar as guest speaker and give speeches on cardiovascular disease during COVID-19 era and an update on APSC consensus statement. Dr. Jack Tan, also the Senior Consultant, National Heart Center, Singapore, as well as he is the Director of Coronary Care Unit of the hospital. He is very good friend of myself as well as Bangladesh Cardiac Society. Once again, I convey my gratefulness to him. It is our pleasure to get him as a speaker in this event of World Heart Day. Dear participants, we are passing through a very challenging and crucial time due to COVID-19 pandemic. Whole world is suffering. Huge number of deaths are there. We have lost many of our friends and members of our some of the members of our society. I, on behalf of Bangladesh Cardiac Society, pray for the eternal peace of the departed soul. Thanks to Almighty. However, we should proceed and face the situation with courage and patience to reach our goal, to achieve our goal. We have to maintain all the health hygiene for our safety as well as for the safety of the others. So today, I also thank Beximco Pharmaceuticals for cooperating us in helping, in organizing this webinar. So let us start the seminar, and I am requesting Dr. Jack Tan to deliver his speech. Jack Tan, please.
Dr. Jack Tan, please requesting to deliver his speech. Kamrul.
Dr. Tan.
Yes. Thank you. I'm sharing a pre-recorded lecture, if you don't mind. Dear friends from the Bangladesh Cardiac Society,
Nashin.
Jack, I'm very happy to be here today for this webinar series organized by the BCS. The picture you see behind me is a picture I took in 2015, the first time I came to Dhaka. And I'm very happy in this very short period of time. I made so many good friends from your country. And it's indeed a privilege for me to share this afternoon with you to discuss the topic. And I also like to thank again the committee that organized this webinar series. I'd like to then to share my slides. Today's topic that I'm asked to give a talk on is on COVID-19 issues, cardiovascular issues during COVID-19 era, an update on, as well as an update on the APSC consensus statements. A date stamp today is the 29th of September 2020, and I hope to have maybe about 10 minutes to share these slides. So again, I would like to thank the Bangladesh Cardiac Society on the World Heart Day, 29th of September, in inviting me to give this talk. I'd like to thank my friends, the President, Professor Mohibullah, as well as the co-chairman, Professor Abdullah Al-Safi Manjavdir, as well as the kind and famous moderator, Dr. Moshin Ahmad, as well as the many panelists and faculty for today's session. So what do we know of COVID-19? At 27 September, COVID-19 has been raging the world over. It has infected 33 million people across the world, killed 1 million of them, with much of the rest of the patients having recovered. In Bangladesh, as of the 27th of September, it has infected over 359,000 patients. It has killed over 5,000 patients as well, with a death rate then about 1.4%, in Bangladesh. I think this only tells half the picture. And the next slide will show you what the picture looks like. As you can see, I think Bangladesh saw a spike in cases by early May. And the frightening things about COVID-19 is that the doubling rate, if left unchecked, is almost a doubling of numbers once every week or 2 weeks. And you can see the same spike in the rise in daily new cases. Bangladesh only started to see a tapering off of cases in the last 2 months. I think the total number of deaths almost identically mirrored the curves of total number of deaths in Bangladesh. As you get more cases, you will get more cases of deaths, and this is a pure statistical percentage. The active numbers will also follow the total number of cases. The total number of active cases will trend the total per day active cases. What is more frightening for COVID-19 is the collateral damage, the lack of access to our cardiovascular patients, and the inequalities for cardiovascular care, education, and economy that manifests. As we go through the COVID-19 pandemic with a time scale across time, I think Bangladesh has witnessed the first wave of immediate mortality and mobility of COVID-19. And most countries are seeing the second to third wave of it, which is a waning and impact of restrictions on non-urgent COVID-19 conditions that cardiologists deal with, like stable ischemic heart disease, diabetes, hypertension. And the third wave is when we do see an interruption of care as our hospital, primary care structure gets swamped with COVID-19 care issues. 6 to 9 months into COVID-19, and maybe longer, we're going to see the fourth wave of psychological trauma, the mental strain, and what is worse than impact in health, impact in economy, loss of jobs, destitute, poverty, and burnt out. I know everyone is eagerly awaiting the coronavirus vaccine. Where are we at now for coronavirus vaccine? I think there are innumerable vaccine trials ongoing, innumerable vaccines in development. There are many different, not all the vaccines are using the same technology. Some are inactivated virus, some are carrying the virus vector, some are attenuated virus, some are pure DNA or virus-like particles, some are viral subunit proteins. So as you can see, the phase 3 human trials ongoing at rapid breakneck speed across the world are testing many different strategies, whether it's a vaccine in effect in Brazil, in North America, in China, or in Australia. They are somewhat different. After this vaccine has been proven to be safe and efficacious, we have to have mass, rapid manufacture to roll out across the world. Not just in the richer countries, but across all countries for us and for the vaccine to be effective. I'm just going to go through a few slides on the latest in COVID-19. The standard of care for public health is that we do need to contain the virus spread through social distancing, masking up, approach of early diagnosis, contact tracing, and quarantine measures. I think the public health measures in more ways are much more important than treating it when it happens. We do need to contain the spread to evidence-based, effective, simple measures like masking up, social distancing, early, effective, accurate diagnostic kits, tracing contacts, and quarantine. We then need to have a strategy to have close monitoring of infected at-risk patients. We know now males, elderly, cardiac risk factors are hypertension, diabetes, ischemic heart disease, chronic lung diseases, smokers. These are at-risk cohorts. And we do need to know when to escalate venturi support when needed, either through prone ventilation to invasive ventilation, if resources permit. We do need to prevent then a whole host of secondary complications in COVID-19 infected patients, like heart attack, strokes, pulmonary embolism, and ARDS. Currently, 9 months into COVID-19 in September now, there's only 2 drugs, remdesivir IV formulation and dexamethasone, which can be also given orally, that's proven to ablate the disease in patients who are fairly ill. These medicines are not cures. And most of the other medicine that initially helped a lot of hope, like hydroxychloroquine, has been proven not to be effective. We know now, at this moment, there's no effective medication to cure the virus per se. Other promising therapies like convalescent plasma and other therapies are still ongoing trials and would not be able to scale up for mass use for infected patients anyway. We are then still eagerly awaiting the first effective vaccine. As a group, we also need to prevent fake news, especially as professional bodies. What are the challenges and opportunities for COVID-19? The main challenge in my mind is the collateral damage for patients who do not have COVID-19 infections. We're talking about patients with chronic cancer, patients with cardiovascular disease, and all these are very much manifested in terms of inequalities for cardiovascular care. And because of that, there's less attention to the growing need for non-communicable disease care as well as research. There are also other black swans or known unknowns that we are actually not so cognizant in taking care. But it's not all lost. There are other opportunities out there. We can, in many models, evolve and leapfrog to new models of care. There's also a desire, as we see in this kind of webinars, to collaborate as well as progress together. I think now we're entering a VUCA 1.0 world where there's lots of volatility, uncertainty. We feel that there's a lot of complexity and a lot of ambiguous situation where we're misreading situations. We do need then to transit to VUCA 2.0, where we overcome it with vision, understanding, courage, and adaptability. I think COVID-19, in a sense, was a known unknown. We knew that a pandemic would come and hit us. We had an experience of SARS, COVID-1 in 2003. So we knew a pandemic would come around. But when it struck us, we were astonished. This is truly one of the known unknowns. What are the other known unknowns for cardiovascular care on the World Heart Day that I would like to talk about? There is a tsunami of non-communicable disease spread throughout Asia Pacific. As a community, we know that we are seeing an ever-increasing number of patients who are afflicted with diabetes, hypertension, obesity, the detrimental effects of tobacco use, and not to forget air pollution. All these things are a known unknown. We know that it's happening. It's going to strike us one day. We need to address and be more prepared when this tsunami or non-communicable disease hit us hard as a community. And there's no better time than on the 29th of September on the World Heart Day to drive home that point. Every day, there are at least 10 times more deaths due to cardiovascular disease than COVID-19. And we should never forget to treat our cardiovascular patients. So I think I beseech the Bangladesh Cardiac Society to take on a leadership role to overcome the volatility, uncertainty, complexity, and ambiguity during this COVID-19 period, and moving forward to address the cardiovascular needs of your patients in terms of non-communicable disease, cardiovascular, and stroke deaths. With that, I'd like to transit quickly to a brief update of the APSC consensus manuscripts. So the APSC has endeavored to come up with a series of manuscripts for use of high-sense troponin T in the emergency department, NOAC use, antiplatelet, antithrombotic therapy, use of P2Y12 receptor antagonist, mitral clip, diabetes, as well as lipid management employing PCSK9 inhibitors. The APSC consensus statement objective was to develop a consensus statements among the region's top professionals for niche topics that does not yet have sufficient Asian-centric data. We want to cater to simple to apply guidance for the wider Asia Pacific. We want this to be contemporary guidance for regional cardiologists and physicians managing cardiovascular disease. A brief highlight for the APSC consensus statements. First one, on the Asia Pacific consensus expert statement on the use of high-sense troponin T. We think that a rule-out pathway with an initial high-sense troponin T of less than 5 may rule out an acute myocardial injury in the emergency department. When it's less than 12 at 0 hours, an increase of less than 3 after either 1 up to 3 hours may rule out an acute myocardial injury and the patient may be discharged. Consider careful clinical assessment and use of risk score validated in ACS alongside high-sense troponin values to inform the decision whether to discharge the patient or follow up in outpatient setting. A simple rule-in formulation of high-sense troponin T of more than 70 may rule in acute myocardial damage. An initial high-sense troponin T value of between 5 to 70 with a rise of 5 and above at 1 to 3 hours also may rule in an acute myocardial damage. Consider then an early angiographic approach to patients stratified to the rule-in group. I'd like then to just show this chart. If you do suspect someone with acute coronary syndrome and they fall within the less than 5 0-hour algorithm, and I'd like to just spotlight here. If they fall within the less than 5, they can be safely ruled out, especially the chest pain onset is more than 2 hours. Again, the nomenclature of rule out doesn't mean ruling out that the patient has ischemic heart disease, and you can consider possible further assessment on an outpatient basis to rule out other. If they fall within the band or between 5 to 70, with an initial 0 hour less than 12 and minimum change of less than 3 between 1 to 3 hours, you can consider a rule out. If they are in this intermediate range and there is also at 0 and 3 hours of rise or fall of between 3 to 5, you can consider observing them with another serial cardiac enzyme check or other means of investigation. If there's a rise of more than 5 nanomoles, consider a rule-in approach with an early angiography, or if the baseline level is 70. In countries where the cath lab is easily available, we can also endorse an upper level of 52 as per ESC. The level of 70 was taken because we do not want to lightly rule in patients in countries with limited resources. A quick one on APSC consensus statement, P2Y121 receptor antagonist in Asia Pacific with a focus on ticagrelor. These are my stakeholders. A quick flow chart which we think might be pertinent to Bangladesh. In STEMI patients who are undergoing thrombolysis, which may happen to a huge cohort of patients, if you do want to switch from clopidogrel to ticagrelor, consider delaying to the next day or at least 8 hours later based on the treat study. We think that this probably is a safer approach. All patients, as best as possible, should continue out to 12 hours. And we do endorse, if you take to the cath lab, an initial DAP regime of either aspirin ticagrelor or aspirin prasugrel with a second choice of aspirin clopidogrel loading. For NSTEMI approaches, we think that if you are going for a ischemia-guided approach or medical therapy, prasugrel is not recommended for this approach. If you are going for early angiographic invasive approach, either ticagrelor, prasugrel, or clopidogrel are suitable for use. We then recommend indefinite single antiplatelet or aspirin if suitable. If you do need to discontinue the medication for surgery, consider discontinuing ticagrelor or clopidogrel for 5 days and prasugrel for 7 days before CABG or any form of revascularization. So these are the standard statements. For STEMI, we endorse a loading dose of 180 ticagrelor followed by 90 BD and prasugrel 60 loading and 10 milligrams daily for STEMI patients. If aspirin and clopidogrel are introduced early in thrombolysis, a switch to ticagrelor can be considered next day or after 8 hours. Likewise, for NSTEMI, the same recommendation for invasively approached treated patients. Unless the bleeding risk is high, a minimum duration of 6 months of DAP is recommended for use to reduce ischemic risk and non-ST elevation MI. There's no specific bleeding risk calculator recommended for use in Asian patients. Ticagrelor or prasugrel in combination with aspirin should be considered as first line for NSTEMI patients at high risk of ischemia, unless the patient is elderly or has prior history of significant bleeding. Please adjust the duration of therapy based on bleeding risk. PPI may be considered for use in patients with high risk of bleeding. However, other causes of bleeding should be investigated. A radial approach is endorsed as a primary strategy for patients undergoing angiography rather than a femoral approach. And this is a previous statement about stopping it for 5 days for aspirin, 7 days for aspirin, 5 days for ticagrelor, as well as at least Plavix, and 7 days for prasugrel. Clinicians must also evaluate the reasons for de-escalation and weigh this against the risk of a possible ischemic event. If you truly think that de-escalation is necessary, please delay it for as long as possible as the risk of ischemic events in revascularized patients decrease over time. Regardless of when and time frame, reloading is required when switching from ticagrelor back to clopidogrel unless there's ongoing bleeding. In terms of duration, the standard duration of DAP is up to 12 months for an ACS. Extension of DAP beyond 1 year can be considered for high ischemic risk patients, for example, those with high stent anatomy or complex coronary anatomy. Clinicians must evaluate both ischemic and bleeding risk. Due to the lack of prospective data in Asian patients, we do not recommend the routine use of point-of-care platelet function testing to guide decisions in antiplatelet therapy. In special population like diabetes, elderly, and CKD, with ischemic heart with acute coronary syndrome, ticagrelor has been shown to be safe and effective. The next one is APSC consensus statements on antiplatelet and antithrombotic therapy for high-risk chronic coronary syndrome. These are my co-lead KOL from across the region. What is high CV risk? If you look at all the trials trying to answer this question with antiplatelet, antithrombotic management, whether it's in COMPASS, DAP, global leaders, Timmins, Twilight, or Pegasus. Of common factors reign: age, diabetes, chronic kidney disease, prior history of revascularization with PCI or CABG, a history of ischemic myocardial infarction, angiographic evidence of disease, or peripheral vascular disease. And we do know that the factors that increase the risk of bleeding also increase the risk of ischemic events, particularly those of advanced age, diabetes, low GFR, prior ischemic events, and the documentation of multivascular disease. And the same reasons for bleed also cross over, especially renal disease, liver disease. There's no definite high-risk CCS subgroup that is well defined in Asia, but the same factors predominate. I think we do know that factors like old age, chronic kidney disease, diabetes, recent MI, multivessel disease, multiple stents, previously a use of BVS, left main stenting, peripheral arterial disease, all these are fairly common risk factors. The ESC also endorsed a high ASCVD risk for those with prior ischemic events, CABG, PCI, DM with end organ damage, with at least 3 risk factors, all type 1 DM or prolonged duration, severe CKD defined as less than eGFR of 30, and a calculated score of more than 10%, all familial hypercholesterolemia. The APSC consensus then recommend coronary angiogram, CT angiogram, or other imaging modalities may be used to confirm a CCS diagnosis, estimate the extent of stress-induced ischemia, and evaluate the burden of disease. Concomitant risk factors should be addressed according to local healthcare standards. Managing bleeding and ischemic risk in Asian patients, intravascular imaging like OCT and IVUS to optimize stent implant is encouraged where available. Drug-eluting stents is preferred over bare metal stents for PCI where available. The bleeding and thrombotic risk of patients should be assessed before determining which antithrombotic regime to use. Gender alone is not considered as a solo factor when assessing bleeding and thrombotic risk. We have come up with a mnemonic in APSC. It's called our CVD mnemonic to document and give some guidance to who we think are the high ischemic burden patients. C for prior coronary event, a high-risk coronary anatomy, or documented multivascular disease, patients with left main stenting, bifurcation stenting, more than 3 stents, and V, vascular, for established peripheral arterial disease, or established cerebral vascular disease. D for disease, defined as diabetes on therapy, a eGFR less than 60, micro or macro albuminuria, and heart failure due to coronary artery disease. If you look at the next vexing question when we talk about antiplatelet, antithrombotic treatment, is defining bleeding risk profile for patients, which we find that this is one of the most difficult things to define. If you look at the stent trials that try to identify who can shorten that duration from bioresorb, leaders-free, Zymes, Onyx 1, Evolve Short, and Zeus, all the risk factors are available here, especially advanced age, oral anticoagulant use, hemoglobin of less than 11, platelet counts of less than 100,000, previous GI bleeding, hospital admission for bleeding in the 12 months prior stroke in 12 months, intracranial bleeding, severe renal insufficiency on dialysis, use of NSAIDs, planned major surgery, non-skin cancer treated less than 3 years, chronic liver disease, expected non-compliance to DAP, or known coagulation or bleeding diastasis. The ARC consensus document try to define the bleeding risk as a binary approach. They have major and minor criteria. You just need to fulfill major or 2 minor. And it's pretty similar. Anticoagulation use, end-stage renal failure, hemoglobin less than 11, spontaneous bleeding require hospitalization or transfusion in the last 6 months, moderate or severe thrombocytopenia less than 100,000, chronic bleeding diastasis, liver disease, active malignancy, spontaneous intracranial hemorrhage, or non-deferrable major surgery while on DAP, and recent surgery or trauma within 13 days. Minor criteria being age, moderate CKD, chronic use of NSAIDs, and mild anemia. If you look at all the risk scores developed by REACH, Dutch Aspirin DAP, Paris, Precise DAP, all these scores were developed predominantly using Caucasian cohorts. There are actually no Asian validated scores out there. The APSC consensus then recommend using the ABO algorithm, which I'll show later, to identify patients who may develop an unacceptable bleeding risk. Advanced age alone is insufficient to confer excessive bleeding risk in CCS patients in Asia Pacific. We endorse a hemoglobin level of less than 9 as an indication for anemia that prompts to higher bleeding risk, as stakeholders across the region feel that a level of 11 is too easy to reach in our Asian cohort where there's a prevalence of thalassemia or dietary insufficiency that may give rise to anemia. The CVD algorithm then can be used to assess CCS patients at high ischemic risk. So this is our ABO algorithm. In patients who are frail more than 75, advanced age more than 85, or an expected life expectancy of less than a year, and this age alone is not by itself, but plus an extra factor like B, prior spontaneous intracranial hemorrhage, recurrent GI bleeding with cause not identified or correctable, a hemoglobin level of less than 9, or organ failure, defined as liver cirrhosis, end-stage renal failure requiring dialysis, bone marrow failure defined as severe thrombocytopenia with a count of less than 50,000, and recent stroke in the last 6 months. We wanted to make this approach as a caution. It's not evidence-based, but we want to make it simple to remember. We want to set the bar a bit higher so that it's a marker to give caution. We do realize that in Asia Pacific, we tend to err on the side of caution and undertreat ischemic risk. So unless a patient truly manifests as high bleeding risk markers in this ABO algorithm, do consider appropriate ischemic risk therapy if they have a CVD algorithm qualifying marker. So a single antiplatelet therapy, aspirin or clopidogrel, rather than dual antiplatelet therapy, is recommended for patients at low CCS risk. Extended DAP can be recommended for Asian CCS patients without high bleeding risk features who undergo complex PCI. Dual pathway inhibition, defined as aspirin, low-dose rivaroxaban 2.5 milligrams BID, is recommended for Asian patients with high thrombotic risk without high bleeding risk features, with concomitant polyvascular bed disease, residual multivessel disease, prior MI or prior stroke. And this is a summary chart showing that in patients who has a desire to transit into chronic coronary syndrome from any acute phase, and they are about to transit from a DAPT regime into a single antiplatelet regime, first assess their CVD risk factors. If they have a CVD risk factor that's positive, for example, they're diabetic, GFR of less than 60, or they have a left main stent, a prior MI, bypass, or they are deemed to have polyvascular bed disease concomitant carotid disease. And if they do have any of these qualifying events, then you assess their bleeding risk by the ABO risk score. In the ABO risk score, if they do not have any ABO risk score that you think confers them an excessive bleeding risk, then consider an extended DEB regime for those patients who have received a complex PCI, namely left main, bifurcation, 3 or more stents in the long segments, particularly the LAD. Consider a DPI or dual pathway inhibitor regime using aspirin rivaroxaban 2.5 BE if you're treating patients with residual multivessel disease, prior stroke MI, or concomitant polyvascular bed peripheral arterial disease, very much like the COMPASS regime. For patients who then have high CVD risk, but unfortunately in the ABO regime, high bleeding excessive risk. For example, you have an 85-year-old lady, end-stage renal failure, hemoglobin of 8, but has a left main stent. When you can transit to single antiplatelet regime, you probably have to err on the side of caution and transit to SAPT as early as possible. For patients who do not have any CVD qualifying factors, they have hypercholesterolemia, they're fairly young, they receive a stent for type A lesion, then I think this group of patients will do well on single antiplatelet regime. I think I would like to stop here. There are other statements, and my slide deck is in the 70s. I've only gone through 2 of the statements. So I have statements coming out for NOACs, as well as for diabetes, followed by dyslipidemia and mitral clip. So I think in the interest of time, I'll stop here, and I would like to focus on the Q&A portion so that I can engage the audience. So with that, I'd like to thank the audience for being so patient with me. The views expressed are personal in terms of the COVID-19 literature. And I hope to have an engaging Q&A session with you guys. And I hope to be able to answer your questions if you have any. So with that, I'd like to thank the Bangladesh Cardiac Society and my good friends for spending the World Heart Day as a fraternity together. I thank you very much.
Thank you, Dr. Ten. Thank you, sir, for your nice statement, APSC statement on the COVID-19 era cardiovascular issue. Thank you. I think COVID pandemic is the global issue, but we think in the regional basis. So I think this consensus is, as a leadership of Asia Pacific region, is very delighted us. Thank you, sir. I am requesting all the panelists, or the expert panel here, but the limited time, only 60-minute times. So please comment or question should be limited time. So I'm requesting Professor H. Luthu Rahman, sir. Do you hear me? Professor H. Luthu Rahman, our Vice President of Bangladesh Cardiac Society. He is a senior professor. Yeah.
Thank you. Thank you, Dr. Respected chairpersons of the session, learned speaker, dear moderator, executives and members of the Bangladesh Cardiac Society, Assalamu alaikum. Thanks to the organizer to arrange this nice program during this pandemic situation on World Heart Day. A lot of thanks to Dr. Jack Tan, President, Asian Pacific Society of Cardiology, and today's speaker for his excellent deliberation and informative speech about cardiovascular and other complications due to COVID-19 infection and its management also. Thank you very much. Thank you once again. Thanks to all. Assalamu alaikum.
Thank you, Professor A.K.M. Fazlur Rahman. Professor A.K.M. Fazlur Rahman, Vice President of Bangladesh Cardiac Society. Do you hear me? Professor A.K.M. Fazlur Rahman. Sir. Any comments, sir, regarding this issue, cardiovascular issue? Yeah.
Thank you very much, organizer, as well as all members of Bangladesh Cardiac Society. We go through a lot of information from the lectures of our speaker and regarding the COVID management and the World Heart Day. So thank you all. Thank you also speaker, Dr. Jack. Thank you very much, and all panelists and all participants. Thank you very much.
Thank you. Professor Sajal Krishna Banerjee. Professor Sajal Krishna Banerjee is the Vice President of Bangladesh Cardiac Society. Any comments regarding these issues? Regarding the heart failure issue, is the most important in the heart failure. Is the President of Heart Failure, Bangladesh Heart Failure Society. Comments on the heart failure and the COVID issue. Dr. Sajal Krishna Banerjee, you hear me? Shafi, please unmute, please. I think Dr. Kajal Kumar Kormokar is the Joint Secretary of Bangladesh Cardiac Society. Dr. Kajal Kumar Kormokar. Dr. Kajal, please unmute yourself. Yeah.
At first, thanks to our chairperson, Professor A.K. Mohibullah sir and Professor Abdullah Sharifullah sir, who is the President of Bangladesh Cardiac Surgery and Secretary General of Bangladesh Cardiac Society. And thanks to Professor Mohsin Ahmed, who is the moderator of today's session. Today is the World Heart Day. This is the big initiative virtual program by Bangladesh Cardiac Society. Thanks to all participants and all panelists to arrange, and again thanks to arrange today's program, and thanks our guest speaker who is the President of APSC for this program is highlighted, and all Heart Days also highlighted, and we have learned a lot. Thanks again to all. Thank you very much.
Thank you, Dr. Kajol. Professor Mahur Rahman Babu is the Joint Secretary of Bangladesh Cardiac Society. Professor Mahur Rahman Babu. Professor Mahur Rahman Babu. You hear me? Professor Mahur Rahman Babu. I think he is disconnected. Dr. Vijay Dotto is the Organizing Secretary, Bangladesh. Any question regarding this issue? Dr.
Thank
Vijay?
you, sir. Thank you, sir. I want to give my special thanks to President Secretary, Honorable Mohibullah sir and Majumdar sir, and also thanks to Moderator Mohsin sir. I want to give a special thanks to Dr. Jack Tan, who nicely deliberated his speech regarding this issue. So thank you all. Thank you all.
Professor Syed Mohammad Mustafa Kamal, do you hear me? Professor Syed Mohammad Mustafa Kamal is from Chittagong.
Thanks.
Yeah.
Yes. Thanks to Dr. Jack Tan Uy, President of APSC, for his brilliant speech on cardiovascular issues during COVID-19. I am benefited by his excellent deliberation. Thanks to the President, Secretary, and the Scientific Secretary for arranging such a nice program. And thanks to all the members who has attended this. Inshallah, in future days, we will be united again. But on this World Heart Day, we will try to disseminate our knowledge, and we will take adequate, we will provide adequate advice to the mass population for prevention of heart disease. Thank you all.
Thank you. Dr. S.M. Habibullah Selim, he's from Sylhet. Dr. S.M. Habibullah, Organizing Secretary of Bangladesh Cardiac Society.
Thank you, Dr. Mohsin, for nicely moderating the program. And also, I congratulate the Bangladesh Cardiac Society chairperson of this session. And also special thanks to Dr. Jack Tan from the APSC. Actually, for our Asia Pacific region, the APSC consensus statement is very much useful, I think, for the daily practice in our cardiovascular disease. And I hope our audience will be more benefited from your lecture. And also, I come thanks to the other panelists in this session for the live session, but because of time constraint, we constrain our speech. And I want to thanks again all the panelists and person and speakers. Thank you all.
Thank you, Selim. Requesting Dr. S. Kamrul Haq. He is from another part of Bangladesh, Khulna, organizing the Bangladesh Cardiac Society. S.M. Kamrul Haq.
Yes, thank you, dear moderator and Scientific Secretary of Bangladesh Cardiac Society, Dr. Mohsin Ahmed, for arranging such a nice webinar. I express my heartfelt gratitude and thanks to Honorable President, General Secretary of Bangladesh Cardiac Society and today's chairpersons, Professor A.K. Moibullah sir and Professor Abdullah Shafi Majumdar, for arranging such an time-worthy and time-tested webinar program on cardiovascular issues in COVID-19 era on the eve of World Heart Day. My special thanks to today's keynote speaker, Dr. Jack Tan, for his excellent deliberation on the said issues. He's also the president of APSC. My heartfelt gratitude and thanks to all the EC members of Bangladesh Cardiac Society and all the panelists. Thank you, everybody.
Thank you. Professor M.G. Ajam, do you hear me? Professor M.G. Ajam is the publicity of Bangladesh Cardiac Society. Professor M.G. Ajam. Dr. Nur Alam.
Thank you, Dr. Mohsin Ahmed, moderator of this session. I must thank to the organizer, especially President Bangladesh Cardiac Society, Professor A.K. Moibullah, as well as Secretary General of Bangladesh Cardiac Society, Professor Abdullah Shafi Majumdar, and all the EC members of Bangladesh Cardiac Society. I also I would like to thank today's speaker, Jack Tan Ooi. We learned a lot from his lecture, especially he mentioned very nicely the APSC consensus regarding the CVD, risk assessment, CVD, as well as the breeding risk assessment by ABO numericals. Thank you, Chen. I would like to draw attention, Chen. Would you unmute, please, on issue regarding prasugrel, use of prasugrel. As we know that in ISR 5 REACT trial, prasugrel is recommended to ticagrelor in PCI patient. And on the basis of this trial, ESC 2020 guideline of non-STSCS, they also recommended prasugrel over ticagrel. But on point is that prasugrel should be introduced with coronary artery disease patient. Without seeing the coronary trees, prasugrel should not be given. But the point is that when a non-STSCS patient, high-risk patient came, the patient is saying for angiogram, should we load the patient with prasugrel, or we see the angiogram? If there is a lesion, if we attempt for PCI, then we can introduce the prasugrel. What is your comment regarding this?
So thanks. That was a great question. Let's look at the current guidelines. The current guidelines suggest that if you were to use prasugrel, you need to know the coronary anatomy, and it's better if it's a PCI approach. If you're going for an invasive PCI approach, you do not load prasugrel. In fact, in the ISR REACT 5, you see the coronaries, you want to do a PCI, then you load the prasugrel followed by a maintenance dose. The rationale for that and for the previous justification, even using clopidogrel, is that preloading, especially for NSTEMI going to the cath lab, 50% of this patient has multivessel disease that ultimately need to discuss CABG. So almost half the patient actually will derive harm from preloading. The problem is that a lot of the Asian Pacific patients do not receive coronary angiogram. and therefore it's very difficult. If you are going to do a coronary angiogram early, the recommendation now, standard of care, is aspirin, Clexane, early angiogram, decide if it's PCI, load during or after PCI. So that is the best standard of care. But in Asia Pacific, that's why it's consensus. There's a lot of limitation. Firstly, in a lot of the Southeast Asian countries, prasugrel is no longer available. We only have clopidogrel and ticagrelor. Prasugrel has been withdrawn from the market. In the ICER-REACT 5 study, also the prasugrel was given as a post-angiogram loading regime. And in the data, if you look at the prescription filling, because it's not a randomized controlled trial, half of the patients do not take their ticagrelor regularly as a BD dose because they only take half the prescription fill up. So I suspect that the data, the real life is such that most patients take an OM dose better than a twice a day dosing for ticagrelor. And that's the truth of it. And I think, and the next point to emphasize is that if you do want to do medical therapy for your patients, prasugrel based on the trilogy ACS is not validated for medical therapy of ACS patient. There was actually more harm. So I think with all this limitation, you have to sort out which area your patient slotted into. If you're going for early invasive approach, I think prasugrel is a very good drug. Thank you. I hope that answered your question. I know it's a bit confusing. Yeah.
Thank you so much, Dr. Nur Alam. Excellent question. Then Dr. Mohammad Jilur Rahman, Office Secretary, Bangladesh Cardiac Society. Dr. Mohammad Jilur Rahman. I think he's not here. One of the representatives of Bangladesh cardiac surgeons of Bangladesh, Dr. Mohammad Shumon Nazmul Hossain, is a cardiac surgeon and the Secretary of International Affairs. Is from Chittagong. Shumon Bhai, Dr. Shumon Nazmul Islam, do you hear me? Dr. Shumon? Dr. Shumon Nazmul Islam? I think network problems is disconnected from Chittagong. I'm requesting Professor Amol Kumar Chaudhary.
Yes, Professor, yes. Now yeah. I can hear you.
Okay. I think.
Thank you.
Cardiac surgeon.
Yeah. Thank you very much, Dr. Mohsen, and all the organizers and the executive members, including President and Secretary of Bangladesh Cardiac Society, for organizing this program, celebrating the World Heart Day 2020. We all know this is a very important annual event for all of us and for the 7 billion human beings all over the world. And this is an excellent way of celebrating the day. We all have been, I'm sure I have been, and I also think that all we have been updated with today's presentation. I'd like to thank you again for organizing this program. Thank you.
Thank you. I welcome Professor Amol Kumar Chaudhary. He's the senior professor of NICBD. Professor Amol Kumar Chaudhary, do you hear me? Professor Amol Kumar Chaudhary. Dr. Muhammad Arifur Rahman. Dr. Muhammad Arifur Rahman, any question regarding topics?
Thank you, sir. At first, I would like to thank our Honorable President and Secretary, Professor Mohibullah sir and Professor Shamimullah sir, and our moderator, Professor Mohsen Ahmed Sohail sir, for arranging this nice session. And I always like to hear from Dr. Jack Chen. He has been a good friend of Bangladesh Cardiac Society and Bangladesh Cardiology for a long time, and he has got special affinity to the cardiology development of in Bangladesh. That's why I thank Dr. Jackson again, and he very nicely and clearly presented the APSC consensus statement, which will be very useful for the treatment of Bangladeshi population, because we know the Asia Pacific region has gone a different nature of disease. So we hope in the near future also APSC will be with all our Bangladesh Cardiac Society and will always update us as usual. Thanks a lot. Thank you.
Another from the pediatric cardiology, senior professor, Professor Mohammad Jahid Hossain, the pediatric cardiologist, senior cardiologist, pediatrician. Professor Mohammad Jahid Hossain, sir, do you hear me, sir? He's one of the representative from pediatric cardiology.
Okay, thank you, Dr. Mohsin.
Yes, sir.
Wonderful President of Bangladesh Cardiac Society, Professor A.K. Mohibullah, Secretary General, Secretary General, Professor Abdullah Al Shafi Mujumdar, and learned participant and learned speaker, Jack Tan, we from Singapore. Assalamu alaikum. Actually, since COVID-19 infection, there has been dramatic change in the protocol of management COVID-19, also with the cardiovascular disease. So I think Dr. Jack Tan has updated our knowledge regarding management of cardiovascular, particularly ACI and ACI specific consensus about and recommendation regarding the management regarding COVID-19 infection, PCI and other cardiovascular disease. I think all the participants who have joined today have been much benefited with his deliberation, and I express my sincere thanks and gratitude to our Honorable President and Secretary General for arranging such an important webinar, webinar. With these few words, I want to conclude here, and I am as a pediatric, I should say that children are also being affected with COVID-19 infection because multi-system inflammatory syndrome, there is coronary involvement, there is myocardial involvement, so there also children also affected in multi-system, and I also mentioned that coronary and myocardial disease also happen in age of children. So I thanks the speaker and the organizer for arranging such a webinar. Thank you.
Thank you, sir. Professor Nawazish Farid, sir, the senior most person here. Professor Nawazish Farid, sir. He's the senior most cardiologist here, present here, I think so. Professor Nawazish Farid, sir. Yes, sir. Yes, sir.
ধন্যবাদ বাংলাদেশ কার্ডিয়াক সোসাইটির সম্পাদক এবং আজকের মডারেটরকে সকলকে আমি ওয়ার্ল্ড হার্ট ডে শুভেচ্ছা জানাচ্ছি। বাংলাদেশ কার্ডিয়াক সোসাইটির সকল এক্সিকিউটিভ সদস্য সহ সকল সদস্যকে, বাংলাদেশ কার্ডিয়াক সোসাইটির সকল সদস্যকে আমি অভিনন্দন জানাই ওয়ার্ল্ড হার্ট ডেতে। একই সঙ্গে বিশ্বের সকল কার্ডিওলজিস্ট, কার্ডিয়াক সার্জন এবং অ্যালাইড সাবজেক্ট তাদেরকে ওয়ার্ল্ড হার্ট ডে শুভেচ্ছা জানাচ্ছি। আজকের এই সুন্দর ওয়েবিনারের অ্যারেঞ্জমেন্টের জন্য অবশ্যই কার্ডিয়াক সোসাইটি ধন্যবাদ প্রাপ্য। সকলের সুস্বাস্থ্য কামনা করি এবং আগামীতে যেন আমরা ফিজিক্যাল প্রেজেন্সের মাধ্যমে এই অনুষ্ঠান পালন করতে পারি। আমরা সকলেই ততদিন আল্লাহ রাব্বুল আলামিন আমাদের বাঁচিয়ে রাখুন, সুস্থ রাখুন, আমরা যেন এই ফিজিক্যালি এই অনুষ্ঠানটা পালন করতে পারি এই কামনা জানিয়ে আবার সকলকে শুভেচ্ছা জানিয়ে before closing, I like to thank today's speaker, the President of the APSC, Dr. Jack Tan, for his brilliant presentation. Thank you.
Thank you. Thank you. Thank you, sir. I think you are in good health. Thank you, sir. Professor Liakot Hossain Tapon. Professor Liakot Hossain Tapon, do you hear me? He's from Gopalganj, I think, network. Professor Liakot Hossain Tapon, do you hear me? Okay. Now, Dr. Abu Muhammad Shafiq. Dr. Abu Muhammad Shafiq, please, if you have any comments or a question to Dr. Jack Tan.
Assalamu alaikum. Thank you very much. Thank you, Mohsin, for giving me the opportunity. And thank you, our President Secretary, who has arranged this program and engaged Dr. Tan, Jack Tan, who have delivered a nice speech to us and refreshed our knowledge in the COVID era. And in this COVID era, we are passing through a very dangerous moment, but we are celebrating World Heart Day. Definitely, this is a time-demanding webinar. So thank you very much. Thank you all for this webinar. Thank you.
Thank you. I am requesting Professor Muhammad Afzalur Rahman. He served as Director of NICBD. For Professor Muhammad Afzalur Rahman. Sir, do you hear me, sir?
Thank you, Mohsin, and thank you, Honorable President Society and the Secretary General for inviting me in this webinar. My regards to all of the executive committee member of the BSc, Bangladesh Cardiac Society, and the today's participation. And my special thanks to the Professor Tan, Jack Tan, for attending this seminar despite his busy schedule. The topic was very excellent and the time-worthy. But I have one discussion and confusion and the question to you. Dr. Tan, are you here?
Yeah, I'm here.
Oh, so you elaborately give the outline of the management of the COVID infection and heart disease. But there is one term that is an acute myocardial injury, and another is a chronic myocardial injury. So how do you differentiate these two, number one? And what is the treatment strategy of the non-ischemic? Is there any special drug or a special measure for non-ischemic myocardial injury? So my first question is that how to differentiate between the acute myocardial injury and chronic myocardial injury? Because we know that if there is myocardial injury and there is an increased chance of the mortality and morbidity in the setting of the COVID. So we must differentiate these two. And number two, is there any special measure or special treatment strategy for this?
Sorry, Prof. Your first question is, can differentiating the cardiac injury from COVID-19 directly versus coronary artery disease?
No. The acute myocardial injury and the chronic myocardial injury after the COVID infection, how will you differentiate that? Number two, and is there any specific treatment strategy for acute myocardial injury, non-ischemic myocardial injury? That is, there is a myocardial injury, but it is not ischemic. That is not atherosclerotic changes. But in myocardial injury, there is sometimes, we find that there is myocardial injury, but there is no ischemia. It could be due to direct viral infection or cytoplasm storm or due to prolonged hypoxia. And
so that's an excellent question. I like to qualify that actually no one knows, but let me speculate. So if you look at Lombardy experience from Italy when they had the huge experience early on, more than half of the STEMI patients coming to the cath lab did not have obstructive occlusive disease, even with terrific injury. So they have myocarditis, ECG mimics of STEMI, but no occlusive lesions, up to half. And it's true that if they have this, their death rate is a lot higher than if they don't have, especially COVID. With this type of changes, they have increased risk of death. So that is the acute phase. And the other speaker was rightly put it, COVID-19 is not a respiratory disease, it's a systemic disease. In the heart, in the acute phase, we have a few series reported or published for cardiac MRI showing that COVID-19 causes myocardial infiltration in even the acute and chronic phases. In the acute phase, this prevalence can in some series be as high as 50 to 60%. But the mechanism of it is direct myocardial infiltrates, perivascular inflammation, and macrophage infiltrates, almost like a transplant rejection type of phenomena and artery obliterations with platelets. And some of this in the intermediate to late phase have obliterans phenomena like adult onset Kawasaki's. So in kids, COVID-19 can cause a Kawasaki-like vascular inflammation. In adults, they can cause obliteration, Kawasaki-like late phase injury. So in the chronic phase, my speculation is that you can potentially have a percentage of patients with two phenomena. One is subsequent increase in the incidence of dilated cardiomyopathy if they have direct muscular damage. Two, they can manifest as adult onset Kawasaki-like disease with atactic vessels or occlusive disease or microvascular occlusive disease. Currently, I think in the UK, they have started 2 prospective studies to follow up this group of COVID-19 patients to see what percentage of patients would manifest as potentially cardiomyopathy or Kawasaki's disease. Currently, what is the incidence, what is the prevalence, I do not know. I suspect it's difficult to predict as well which patient will get it. In Singapore, I did review a series of post-mortem cases of 13 cases, and they're all varying age group. And some of them were not aware of having COVID-19 when they had sudden death, presenting most likely as arrhythmic deaths. So I think, and some of this death, if there was no post-mortem, may not have been attributed to COVID-19 as well. So I think this is going to be a vexing problem. And in the acute phase, I think you have to be suspicious of COVID-19 direct myocardial arterial thrombi or myocardial infiltrate or myocarditis. But I want to caution that we still need to treat standard AMI as standard based on guideline mandated treatment for COVID-19 infected patients. Because in the at-risk group, which is the elderly, the male, the DM, the hypertensive, they are still more likely to have acute plaque rupture AMI physiology when they're stressed by COVID-19, not COVID-19 myocarditis. So I think we still need to treat them as per guidelines for them to have their best outcomes and not to confuse COVID-19 effects versus coronary artery disease precipitated by the stresses of hypoxia. So I think every case is different. There's no standard treatment or guidelines, and I think we need to be careful about making assumptions when we treat in the acute phase. In the chronic phase, I think if the patient does present to you and the typical symptom is this, they come to you, they are quite young, they have COVID-19 infection in the previous 3 months, they continue to have atypical chest pains. And some of these patients, if they have myocardial injury or infiltrates, they can have microvascular obliteration causing the chest pain, but you cannot pick it up. CT scan coronary arteries will be normal. They may be MRI changes, or they may be regional wall changes on 2D echo. So be aware of this group of patients. Bangladesh has over 300,000 documented infected patients. There may be more undocumented ones. Some of them may present to you as atypical chest pain or heart failure subsequently. So I think just be aware that and think of this when they come and see you. Thank you very much. Again, I'm speculating. I'm not certain.
Thank you. Time will say, because it is continued research. At the end, after a long time, needs to conclude the acute injury and chronic injury. Thank Dr. Chen for your comments. We are near to the ending of the program. I just want message for every WHO. Just slogan: we should love ourselves. We physician, we should love himself first, then love ones, and then the society. So take care of yourself, prepare for COVID pandemic. And one issue is for the Bangladesh Cardiac Society and APSC. For the health heroes, they're working in the pandemic. We should do for the health heroes. That is, thank for the healthcare professions. They are doing a lot in the COVID pandemic. So showcase our everywhere for the heroes. So I request Dr. Ten, please take some steps for the heroes working in Bangladesh, also Asia Pacific region. They are for the heroes. Thank you, Dr. Ten. Now, vote of thanks, Professor Abdullah Shohibandar sir, our General Secretary, our leader. He organized the program, planning this program. I think Professor Abdullah Shohibandar sir, give the vote of thanks.
Good afternoon to everyone. We are very short of time actually, and the box, the Pandora box, which is opened by Dr. Jack Ten, it will take some hours to discuss by the faculty and the attendees present here. So we have to cut short, and we are in the novel corona pandemic. So we have to follow the novel way to have observed the World Heart Day. Because in every year we observe the World Heart Day by making our rallies, the symposia, distributing the leaflets, etc. But this time we have to observe it remaining within our own rooms. So, but it helps us to bring us many faces together in the same platform. So, and we are lucky that we got our president of the APSC to have with us with this novel meeting. So with this few words, and as we have already crossed the scheduled time, I again thank everyone, every organizer, our president, our scientific secretary, our members of the executive committee, all work hard to make it successful. And also we have to thank Beximco Pharmaceutical, who is our scientific partner to make this program successful. And again, thank you, Dr. Jack Tan. And once again, we hope we will get you in another webinar to have some discussion, which is raised by Professor Afzalur Rahman in details. We can have that COVID issues. And with these words, and with the thanks to everyone, I conclude my remarks. Thank you very much. Thank you.
Dr. Jack Tan, any comments after Dr. Jack Tan? Any comments for the society?
Yes. I'm very fortunate to spend the World Heart Day with everyone. I know everyone is working very hard. On top of thanking the frontline workers, I'd like to acknowledge our nurses and all the other frontline workers out there in Bangladesh, the policemen, the teachers, even the vendors. I think everyone needs to keep together and keep safe. I want to offer a lining of hope to say that COVID-19 will not be with us forever. But I tell you, cardiovascular disease will be with us forever. So I need all of you all to keep yourselves safe so you can continue to treat our cardiovascular patients well. So with that, I'd like to thank everyone for the time this afternoon. And I really enjoyed myself. Thank you very much for your time.
Thank you. Now, conclusion, Professor A.K. Mohibullah, sir, please conclude the session.
Thank you very much, Dr. Tan. As a part of APSC, Bangladesh Cardiac Society is also a part of this consensus statement. And we hope that in future from Bangladesh Cardiac Society will be a part of it. And we hope that every clouds have a silver lining, and we are waiting for that silver lining to overcome these present challenging situations of COVID-19. So hope to see you again very soon. We will be organizing our next conferences virtually, probably during this December, and we will contact you also. And we may have met on 3rd of October, extraordinary General Assembly meeting. I think so, in virtually. So thank you very much, Dr. Tan, for giving us the time. Very good friend of Bangladesh Cardiac Society. We are very much grateful to you. Thank you very much to all the participants, our executive committee members, our Secretary General, all the secretaries and vice presidents. So thank you very much for giving the time. And here I am concluding this webinar seminar. Thank you very much once again.
Thank you so much.
Thank you.
Thank you so much. Goodbye.
Thank you. Bye-bye.
Goodbye.
Bye. Keep safe, everyone. Bye-bye.
Bye.
Take care.
Take care. Take care.